Welcome back to another episode of The Learning Curve, the podcast where we spotlight bold ideas, rising educators, and incredible clinicians that are reshaping how we teach and learn in medicine. I am your host, Dr. Irtaza Asar, and today we're taking on a topic that's as urgent as it is under-recognized in medical training. Every day, victims of human trafficking walk through our hospital doors, and many leave unnoticed. As healthcare professionals, we may be one of the few opportunities they have to find safety, dignity, and support. In this episode, we're diving into what trafficking looks like in the clinical setting, how we as providers can recognize the subtle signs, and how we can prepare the next generation of clinicians to respond with empathy, knowledge, and skill. Joining me today are two incredible clinicians, Dr. Katherine Schaffer and Dr. Megan Powers. They are incredible physicians currently practicing at EVMS at ODU, and today they're going to share their expertise in how we can better understand the realities of human trafficking in healthcare and how we can equip clinicians to make a difference, one patient encounter at a time. Thank you guys so much for joining me. I really do appreciate your time.
Thank you so much for having us.
Yeah, thank you.
This is going to be a fantastic episode, and I really think this is one of those areas of what I almost call a blind spot in medical education, where a lot of providers don't really get any formalized education on this. I can speak from my own experience. I never really got this formalized education, so I think this is going to be a great opportunity for listeners that are tuning in. One of the things that I wanted to start off with before we dive into this is some of the incredible work that you guys have done with victims of human trafficking. Can you guys talk to me a little bit more about your clinic? Just give us a little bit more insight into kind of what led to that and what inspired that and how that's been going.
Yeah, absolutely. So Megan and I met when we were both medical students. She was a second year medical student while I was a fourth year, looking to find ways to impact our community. And both of us had a lot of experience with, specifically me, working with our underserved homeless population, while Megan's had the chance to work down in New Orleans with a nonprofit organization that's on identifying human trafficking and responding. When she was discussing wanting to go into emergency medicine, we actually met up and we talked a lot about our similar interests. And one of the things I recognized during my work with our homeless population is that the patients that we saw had high risk factors associated with human trafficking within our homeless clinic that we worked with. So we made a decision to open a new free clinic that provided trauma-informed care, because one of the things that we recognized was it is hard to create connections within less than 15 minutes with our patient population who've undergone some type of mental, physical, emotional trauma. And how do we best serve that underserved group? So that was when we decided to create Blue Heart Clinic, which has now been running for Megan, about 4 years now?
Almost 4 years, yeah.
So we looked at training medical students and training residents, as well as attendings, on understanding the basics of trauma-informed care, focusing on those who've been impacted by human trafficking, sexual assault, and domestic violence. By doing this, we have been able to identify patients within our emergency department, within our hospital setting, and getting them referral process over to our free clinic, where they are then able to see multiple specialties. We have our primary care team, we have mental health, we have therapy teams coming in, and we also have our women's OBGYN. And this allows them an hour to get to talk to one provider, and then if they need, they can then have another established appointment with another specialty that same night. So if this is the only night that they could be seen, they could have 3 appointments for each specific need that they have to be addressed. Other stuff that we've done has really been able to provide our students the opportunity to be patient advocates and getting the opportunity to work with our patients very closely, understanding who they are as people and also what it is that they have been hesitant about with medical care. And then how do we bridge that gap and understand better so that we can provide information to our other colleagues in creating safe spaces for these patients.
That's incredible, and you guys have done incredible work, and I'm so excited to have this level of expertise to talk about such a sensitive topic that I really think can help a lot of great educators that are out there that are looking to revamp their medical knowledge about topics like this. And again, like that idea you said, 15 minutes really isn't enough to build rapport and dive into some of these issues that our patients come in with. And having that hour and looking at patients through that trauma-informed care lens, I think is fantastic. I think that's an incredible thing that you guys are doing, and I hope that you guys continue to find incredible success. So really excited to hear about all the growth that you guys have had from that standpoint. So I think that's actually a really great segue into talking about human trafficking. Megan, one of the questions that I think frequently comes up is a lot of folks don't really have a strong understanding of what exactly is human trafficking. Can you give us some definitions with regards to this and also define things like labor trafficking and domestic servitude and tell us what the difference between all these things are?
Absolutely. And I think that is something that we're really trying to increase in awareness in how we train our students, whether that be medical students, nurse practitioner students. We have a whole variety. And we also have the opportunity to teach physical therapists. It's not just medical students that need to understand this because there's a lot of nuance with human trafficking. And so often, something that always gets brought up in every training that we do is everyone naturally thinks of international human trafficking, which, to be fair, there's been a lot of movies that have come out that talk about it. Everyone, at every single training, someone always brings up the movie Taken. That's what they naturally assume trafficking is. And that's quite fair because the propaganda, the images we've used, typically hone in more on the international side of human trafficking. And so, what Katherine and I have been trying to do is recenter and refocus how we teach human trafficking because it has to be from the lens of what it looks like in America in order to be able to identify patients properly. So, for us, you have to include the official definition, which anyone can look up, but it's kind of all of these big fancy words, but we really try to break it down for students that it is any form of power differential that someone has over someone else, whether that be through coercion, like when we're talking about the basics of human trafficking, someone has power over someone who's at risk, and we go over all the different types of risk factors for human trafficking, but that could be someone having a need for a visa, food, housing. Sometimes it's in the form of a transaction such as sex. Sometimes, as you mentioned, it's labor trafficking, but it's any time that someone else who is in power has a differential, has a way of manipulating someone for a service. And that's where we really go through and we break down the types of trafficking because, as I mentioned earlier, the type that everyone assumes is sex trafficking, which, yes, that is an issue in America, but there's also a lot of different subtypes that people will easily miss because it's not in this obvious imagery or presentation that we sometimes lead ourselves to in the way that we use images and we create our own bias.
Excellent. And I think that's actually a fantastic overview of human trafficking in a nutshell. One of the things that you brought up was certain misconceptions. Specifically, just to dive into that a little bit more, are there any other misconceptions that you feel often cloud our judgment in the clinical setting?
Absolutely. I think one of the biggest things and what we really try to focus on is the imagery and how we create this idea of what a patient is going to look like. We do understand that most of the survivors that we're going to deal with are women and children, but there also has to be this understanding that men are often labor trafficked, young boys are often sex trafficked. And what we typically come to find out is a lot of people have this idea because they think of this image of a woman in a cage in some form of bondage with their mouth duct taped. A lot of organizations love to use that imagery, but that honestly sets us up for failure in the clinical setting because our patients are not going to look helpless. Many of our patients have had time in jail. Many of them have drug history, alcohol use, a list where we typically label them as psych patients rather than getting to the root of why they're doing what they're doing, which is because they've been trafficked and abused for years. So I think that's one of the most common misconceptions that we have to deal with, in addition to it only being a lower socioeconomic class that's at risk. Yes, there are certain risk factors we have to go over because as you put the clinical picture together, it can help you determine whether someone might be at risk for trafficking, but we also tell our students stories of really prestigious families that a family member was trafficked. And so it's kind of shedding light. And some of the students are taken back of the variety that can be seen in how someone presents. So that's why we really teach them to look at body language, put the story together rather than having this one singular image of what someone should look like.
I think that's actually a wonderful way to address some of these common misconceptions that individuals might have regarding this topic. Thank you for shedding some clarity on this. Can you help us understand the broader scope of this issue, both globally and locally?
Yeah, absolutely. So in a global sense, yearly, there's about 49.6 million people that are trafficked worldwide, and approximately 12 million of them are children. So that is not really based on country to country, but just statistically, when they do the census every year, those are the numbers that we're getting.
Yeah, and you think about that, that's a pretty significant amount. And again, it really echoes to us as clinicians and providers that are listening out there that, it's on us to hopefully identify these vulnerable patients that come in walking through our clinic doors or our emergency department doors. Now, having established the gravity of this problem, Katherine, can you talk to me about some of the red flag signs that we should be looking for in a busy emergency department?
Yeah. So someone who comes in with a partner, that's, just something to be aware of, and specifically the visual aspect of it, right? It's not just, hey, this person's with someone else. It is, how is their behavior when they are with this other person, whether it be the person is solely speaking for them, the patient is more hesitant, more withdrawn, anxious appearing, whether their clothing choices are inconsistent with that of the actual day and what the weather is appearing. So they could either be very overly dressed in 4 layers versus having minimal clothing within winter time. Other things that we look for is, avoidance of eye contact with your provider, whether they're always looking over. So for example, if I'm always looking over at Megan when I'm being asked a question to get the okay that this is something I can say. And if my story is making sense, or if she has to fix my story, is there any inconsistencies with it? We look for tattoos, which can have some meaning, whether it be branding, whether it be property. We've had someone even walk in before who had property of someone. We couldn't fully understand it, and it was really just a conversation of, hey, what does this mean to you? Because we need to understand more to make sure that you are safe. But those are really the things we look for in those inconsistencies in that presentation of our patients. And that means having very hard conversations, yes, separating the patient and that person, but also being okay with not looking at your computer, not looking down, even using a screening tool sometimes, because those have all the questions that you want to be able to ask, but it's so difficult when you ask it to continue to look at your sheet of paper without watching that response from the patient. And that's one of the things that we've really tried to work on with our group.
I think that's actually a really great overview of certain presentation patterns that we really should be aware of, because if you see that internally in your mind, you're like, hey, this is a red flag that I really potentially need to start to investigate more. So from your guys' standpoint, let's say you have a situation where some of the things that Katherine, you brought up start happening in the clinical setting. We recognize it. Now, how does that translate in terms of how we respond to this? What are some do's and don'ts, Megan, that we can incorporate into our clinical practice that can really help guide us through this situation?
Great question. That is one of the things that a lot of our students get nervous about and want to know, and even our residents and attendings, because they're very passionate. They want to be able to identify people, but then it's the next step, like, what do I do now? And I think there's going to be some cases where they self-identify, where there's disclosure that they're being trafficked. And then there's other times where it's going to take multiple visits to the emergency department, multiple visits to the outpatient clinic. It just depends. It's very survivor and very patient dependent. I think one of the most important things that you can do immediately after you find out information, whether they're honest with you, whether there's this discourse between the patient and the other person that might be their trafficker or pimp, I think it is to make sure that they understand that you are there for them, that you are on their team, that there's no shame or judgment. I think that's one of the things that we really focus in on our training is the phrases that we use and understanding our own bias and how we project expectations on our patients, because that is also going to lead the path in how we can actually take care of them and their willingness to accept our care. Because we can provide all the protocols in the world, but if we do it with a judgmental tone or one of looking down upon them because we don't understand why they were put in a situation they were, they're not going to want to receive our care. And so we teach our students a lot about the phrases that we use, thanking them, because a lot of them have never been asked their opinion. They've never been asked what they think of a medical plan before. Everything has been forced in their life. So thanking them, asking them if they're comfortable with the plan, if they're comfortable giving information, making sure that they feel like they are an integral part of the medical team is a way for there to be an ease in progression of how you take care of them. And then also just assessing their safety. That's one of the biggest things that you can do. If they don't have a place to go to, or if they have to return to the person that might be causing them harm, what we encourage people, varies in each city that you're in. We're very fortunate that we work with several amazing organizations that have been able to partner with us to provide safe housing. But that is also something that the clinician, the hospital has to kind of take ownership of, is finding good, well-known organizations that can help with safety and getting them to a safe house. And I think that's an important step, but also recognizing that you can't force them to do that. And one of the things we really try to do is take away the survivor bias or the survivor complex in our care, is because some people are going to say no, but you still have to provide the resources.
Great points. And I think one of the key things that I would stress to our listeners is this is really a moment where you want to try to involve them in their care and validate their autonomy. Because again, you have these individuals that have never been in this kind of situation before where someone is validating and involving them in their care. So I think that's something that was really, really important to stress. And Katherine, just to kind of piggyback off something that Megan said, real time, let's say we find ourselves in this situation. From a hospital system standpoint, absolutely, we need the support of the hospital. But in real time, who else should we be looping in to try to address some of these challenges that come up?
Yeah, we've actually had a number of cases where it's been very challenging to try to figure out, who is the person that should be leading this conversation. When it's a child, you have this understanding child protective services need to be involved as soon as possible. Law enforcement needs to be involved. There are very clear guidelines as to how to help those children. But when it starts to get to more of an age of adult and consent, that is where there's a lot of discordance and difficulty with trying to understand who is in charge. So one of the things that I definitely recommend for everyone is when you are having this conversation with the patient, make sure you're doing it separately. One of the things that can happen is that you address this in front of the person you are concerned of either trafficking or harming your patient. And that can create a lot of animosity, a lot of distrust, both within the patient and that other person within the room. And so then trying to create a meaningful relationship without having them leave would be incredibly challenging. So initially trying to separate them, allowing them, hey, I need to do a physical examination that has to be separated from you. I'm really sorry, but we will need you to step out to the person that's within that room, not giving them that choice for the person in the room and making it on you instead of having to say to the patient, are you okay if this person leaves? Because they may be hesitant, not know how to respond because they understand that that person doesn't want to leave. So that's kind of your first statement. And whether it be you as the provider or nurses, techs, someone else within your team, as long as someone is capable of creating a relationship, it doesn't always have to be you as the provider. But if there's anyone within your team that has the inkling of those red flags, those spidey senses that something's going wrong, to then address it and to say, hey, let's have this conversation. You may say to the patient, are you being trafficked? But they don't most likely know what that exactly means. And so asking those very specific questions of feeling pressure to do things or having to do things to create means of survival will better understand for both you and the patient of what may be occurring at that time. And then going into who's the next team member. Just like Megan was saying, we have very amazing local resources within Hampton Roads. We have a human trafficking task force at Hampton Roads that works with our government. And so they've already identified over 200 plus cases within Hampton Roads, and they are willing to give us their numbers to have these very difficult conversations. So I recently contacted them and was talking through, what is this next step? Because this person isn't a minor. And some people want to get detectives involved right away, but with that can bring a lot of difficulty because there can be bias associated with it. If this person doesn't want to leave, they can make the decision because they are an adult. And it also depends on legal aspects, right? Which states are mandatory in reporting. And so Virginia is not mandated to have to report. You can do the national tip line to just let someone know. But if the person decides to go back to that situation of a trafficker, that's one of the hardest conversations as a provider to say, okay, this is their decision and I have to be okay with that. And hopefully I created a safe enough space for them to come back if that's what they need.
That's something that I think in talking to other clinicians about this topic and even in preparing for this podcast, one of the common questions that I had from a lot of folks is, hey, how do you balance your duty to report while also honoring patient autonomy? And I think that's actually a really interesting thought point that you brought up. And I just want to pick your brain about that is if, let's say you're encountering a clinician that's dealing with this for the first time and they ask you, hey, how do I really balance this? Is, I feel compelled to report, but at the same time, I want to preserve their autonomy. What would you tell them, and what's a good way to address this for some of our younger learners that are out there?
So learning more about your laws within your state, that's a huge one, because if it is not mandated to report, then the patient can decide, I don't want this brought up. I don't want police involved. I'm making the decision to leave, and you have to respect it. And you're not going to, call the police and have the police show up and detain this person for making a decision that they're capable of doing. And that's really, really hard for providers. I know I've struggled a ton with it. We've had patients on our trauma services who've been pushed out of windows from 3 stories up, and you are part of their whole treatment team. You talk to them afterwards once they get medically more stable, and the decision was to return. And saying, is there going to be something that happens down the road, whether this person comes back more harmed or even able to communicate with you? I mean, I struggled for a long time, and Megan and I had many conversations about this, and it is recognizing that because I created, and we created as a team, a safe space, that is what you could do. And you don't have control over what other people do, but you recognize that you're able to provide at least some kindness that they can hopefully one day see that there's a safe space for them to come back to. But it is like the conversation that Megan has, right? Where, we're not trying to save them. That's not our goal. It's to let them know that they can have power and let them know that there are safe places for them. And by being there for them in the provider realm, they can hopefully come back.
It's an incredible answer, honestly. And I think that's something that I've personally struggled with as well, where you feel like compelled, hey, I think you should make this decision, but ultimately you realize that this is not my decision to make for them. They have to have that realization. They have to understand the power dynamics that are at play. They have to understand their own vulnerabilities, and giving them the resources, the options, I think ultimately is the best thing, because then they can recognize that, hey, there's this individual out there that potentially I can reach out to for help. And if I come back to this emergency department, there's other people in this department that could potentially help me with the situation that I'm in. So I think that's actually a really wonderful answer. Now, one thing that I also wanted to ask about, and Katherine, I want to pick your brain about this, is we miss a lot of these cases. What do you think gets in our way from a system standpoint and even like a provider standpoint that really puts us in a situation where we're not catching these cases like we should?
I would say a lot of time constraint. It is quite challenging when you are in a very busy emergency department, as I know a lot of us have dealt with. You have time numbers you need to be hitting, patients within the focus care fast track area, which is where many patients of our population may be going to due to pelvic pain, due to dysuria, concern for STD, STI. You get that chief complaint of STD exposure. They come in, instead of asking, especially if you've seen that they've been there 50 times, instead of asking why, it's, oh, well, they're just here for another annual checkup. They can be discharged right away. And so there's this moment of time. You have less than 15 minutes to get these people in and out. But then there's also, you see the red. And when I mean red is you see all of the encounters that this person has come to. And that can create, and I know this has happened for me, is that you see that and you're saying, man, why are they here again? And that's your own bias kind of reflected off onto that red screen, and you make the decision, there's not much more I need to have a conversation of because I know why they're here. And breaking through that and recognizing, oh, there's possibly something else going on, and having just a small conversation. Doesn't have to be a full, 10-minute talk, but asking why. And a lot of our patients have actually expressed, if someone just asked me why, when I was there over 50 plus times, I think I could have probably talked about what was happening to me.
Yep. And I think that's such a key, especially for some of the younger learners out there, is they'll open up the EMR and they'll say, hey, there's 15 visits this month, and they'll start to get frustrated. But one of the questions that I try to impart on them is, hey, go in and actually try to figure out why they're coming in 15 times this month. Is there something more that's going on from a socioeconomic standpoint, or is there something happening in their house situation, their personal lives, that's leading them to keep coming back that we can potentially help them with? So I think that's actually a great point. Megan, one of the challenges that I feel like a lot of folks have is at the provider level, specifically with lack of awareness and training. Can you talk to me more about that and how that can contribute to us not being able to recognize this issue?
Oh, yeah. That very question, that very issue is what led me to start my nonprofit almost 5 years ago. I also think it's the type of training that we provide. I remember when I first started this, I did a lot of research on the different types of trainings, what were out there. There were a lot of videos on YouTube. There's some great, really well-known organizations that create this incredible online curriculum, but it's often taught by physicians to physicians. They bring in a survivor to talk about their story, talk about certain things that a lot of people respond to because it's more of a visceral response of, wow, this story was incredible. People love to hear this Cinderella story. I was in trafficking and then I was brought out. That's not really the case for a lot of the people that we're going to be dealing with. So not only the type of training where, yes, online curriculum is fantastic. I create online curriculum through my nonprofit. I work with a lot of other organizations, but it's also implementing very much more real live scenarios, having in-person training, bringing in survivors, and really transitioning from how we incorporate survivors, not where they tell their story, not where they just bring in these facts and statistics, but really bringing in what they wish their provider would have done. What are little indicators that they were giving their provider that were overlooked? And then how do you create proper rapport with patients? Because I think that's also one of the biggest gaps in how we provide care and how we train physicians and providers is because we're so systems based and we look at the different things, we look at the different symptoms and we want to come up with a diagnosis. But as Katherine mentioned earlier, reading the body language, putting the pieces together, asking deeper questions, sometimes we're just programmed to not really have time or really have the foresight to think about that because we're more focused on, well, what can I understand? What can I get out of them to have a diagnosis? And sometimes coming up with the fact that they're being trafficked takes multiple visits. And we really try to train our students, our providers, that you have to look at the small things that they're communicating and also read their body language. If you ask a question and they are saying one thing, but their body is telling you something else, they're more resistant, they are looking away from you, you have to understand those small signs. And I think a lot of trainings are starting to incorporate those, but I think that is some of the biggest gaps in our medical training from previous years is we're having physicians who have limited exposure have been reading about it through different articles. And I think research always has a place, but it's also you have to have exposure and time with survivors to really understand how they're going to respond to certain types and levels of care.
Awesome. And I think that's actually a great overview of some of the provider level challenges that physicians, nurses, physician assistants, nurse practitioners all encounter probably when dealing with this issue. So I think Katherine gave a great overview of the system level challenges, and I think you brought up challenges that providers face. Are there any patient level barriers that we should also be aware of?
Yeah, I think that one of the things that we really have to focus on is the mistrust of authority. So when they're younger, there's an opportunity, whether it be in, if they were in foster care, for example, to have some type of conversation with authority. And if nothing ever came of it, that mistrust builds. And once they start to cope, which coping can be dealt through a lot of different ways, but alcohol, drugs, and then other things that if there's someone who may be undocumented, there's a fear of deportation. There's a fear of if I come forward, they find out that I'm not actually from here, I will no longer be able to live and support my family even at home who's back in the other country. So these are different aspects that people may be fearful of coming forward for.
Perfect. Great. That's a great overview of some of the patient-centered challenges that we might be encountering whenever we're running into these cases. And I think something that you guys have echoed that I really want to dive into is how we can integrate raising awareness for these issues, especially in our medical education. So Megan, from your standpoint, what can we do better to integrate this into our curriculums? And where does this really fit from a graduate medical education standpoint? Where can we incorporate this?
I personally believe that the earlier that we incorporate this and make it mandatory in medical training, the better, because as they get more accustomed to the type of training, as they get more comfortable with dealing with these encounters, they're more likely to implement this in their actual clinical practice. If we implement it when they're first and second year medical students or PA students, the likelihood of them wanting to incorporate it overall and use it in the hospital increases. So I think that if there is an opportunity for people to implement it and propose it to local medical schools as using it as part of their clinical skills, because that's a mandatory aspect of all medical training. You have to have clinical skills and clinical time to really understand how to talk with patients, how to do encounters. I think that is the most effective way. But for places that haven't had previous required training, I think really if there's a hospital that is run by residents, I think that is the most effective way to really get that training going, is because if it's an academic center, the residents are really the ones that are going to be seeing the patients the most amount of time. They're going to be relaying things to the attending, but they're going to have the most face time with patients. I think incorporating it with resident training, if you can get it involved, incorporated into nursing training, and it doesn't have to be this extensive 4-day course. It can be really a series that you have over lunch, which that has been a way that we've been able to incorporate it into certain hospitals, is really just having clinical, practical training that says, hey, if you have some of the indicators, if you have this instinct or this gut feeling that something's wrong, these are practical ways, and just getting that conversation started. But I really think focusing on nursing and residents, if available, just having those lunch hour trainings, whether that be over a week, whether the course of a month, I think that is the most effective way if you don't have the opportunity to incorporate it into medical school training.
Perfect. I think that's actually a great overview. I absolutely agree. I think integrating this earlier on into your medical education, especially when learners are trying to practice having difficult conversations and also recognizing some of these challenges early on in their career, I think can really help set them up for success. And I think that's a great point. If you're at a facility that utilizes a lot of residents that are involved in direct patient care, really targeting them, especially early on during their earlier years, I think is going to be more beneficial and help us raise awareness for this issue and help us recognize it better. So let's say we integrate this into our medical education. From your standpoint, how can we teach this in a way where it helps our learners recognize this issue, helps them address it, but also keeps that trauma-informed lens into perspective?
So just an example of what we recently did at Eastern Virginia Medical School. In our emergency medicine residency, we did a quick, just kind of case-based learning simulation setting. We had people who had never undergone trauma-informed care before have a simulation of patients who've been trafficked, domestic violence, sexual assault, and how do they have those conversations without any training. And then we transitioned them into having this 1 hour long training with Megan and myself to really go through the aspects of what is trauma-informed care, how do you best approach it, and then also what is it that you can do and how do you appropriately document. And then the group that hadn't first gone through the simulation went through the second simulation, and they had, after having been exposed to the teaching, they got to see what it was and if they could implement what they had learned. So these are different things that we've done at EVMS, where we try to bring simulations in. We try to provide very challenging conversations and how to make our residents and even our med students who've been there comfortable with being uncomfortable in those sites. And then also by being able to talk through and give cases. We do usually about an hour. Sometimes we go a little over, just depending on how excited Megan and I are in that day. But we will give a presentation that talks through all the red flags. It's very interactive. We want people to be able to tell us what they think. There's no judgment zone, right? We want people to express like where they feel like their bias may be, and we can break that down and we can talk through it. But we also love that we can do simulations with our standardized patients at EVMS. They provide an amazing opportunity for you to have these hard conversations without the fear of being, you say something wrong, or is there something else that I could have said differently? This is just a great way for people to learn how to have these conversations.
Absolutely. And honestly, I think those are some fantastic ideas. And if I'm an educator and I'm hearing this idea, and this is definitely a gap in my medical education and my medical knowledge, odds are it's probably a gap for my residents. So I think some of the things that you're saying are easily incorporated into clinical education, and I think could really help benefit learners that are out there. So I think that's fantastic. So as we're getting ready and time is ticking down, one of the questions that I always ask every single guest that I have on is, hey, if I'm a first-time listener, what are the 3 key big takeaways that I can take away from this episode?
Trafficking is very much an American issue. I think if we can get that in people's brain, I think that will help a lot with expectations, that it's not just if they're going to see someone who's being trafficked or abused, it's preparing for when they will be. I think that's a huge takeaway.
I think we are truly the front line. Anyone within the hospital, anyone within clinics, you are your patient's advocate. And so by being able to recognize red flags and being able to know, who to contact, what the next step is, how to provide that safe space, I think that you can create such an amazing environment for our patient population that you definitely are that frontline person and the biggest patient advocate.
Absolutely. Megan, you were going to say something?
Yeah. And 3, getting away from feeling the need or the pressure to save them. In a clinical setting, it's really about incorporating them where they build trust, where they can return to where you are because they trust you as their provider. And the more that you can make them feel like their voice is heard, that their opinion and their choices within their medical care matters, as Katherine said about the point of being an advocate, that is most likely where you will find success in even proposing plans of finding them safety and getting them away from their situation. The more that you incorporate them where they feel like they actually matter, the more likely you are to find success.
Excellent. I think those are incredible takeaways. And really, for me, I think one of the big things that I've learned from you guys and the expertise that you've been showcasing for the last half an hour to 45 minutes is really, I think this is a healthcare centered issue where if we can educate our physicians, our nurses, our PAs, we can really help to break the cycle of exploitation that continues to perpetuate. And I think there was so many great takeaways that you guys brought up. Do you guys have any last minute closing thoughts? And I just want to make sure I give you guys this platform to be able to articulate something that we might not have planned, but is there anything that you guys would want to add on to something that we didn't touch on?
I think one of the things that we've been really lucky at UVMS is the openness with our medical education team in the undergraduate medical setting. We've had our clinical skills providers be willing to have us come in and talk and provide simulations, but we've also integrated it into our emergency medicine clerkship. And so every month, 18 students plus will get the opportunity to come through and talk through these cases and talk through all the various points. And I think by being able to integrate it into some type of curriculum in one of the clerkships, that has truly opened the opportunity to touch as many students as you can and learners.
Awesome.
And then I can't believe I didn't bring this up earlier because this is one of my very passionate talking points. And going back to how Katherine and I provide trauma-informed care and how we teach is also really trying to get away from providers hyperfixating on getting a sexual history if it's not related to the clinical presentation someone is coming in with. That is one way to cause significant re-traumatization to a survivor, is if they're coming in with a shoulder injury and you're fixated on the number of sexual partners they've had, that makes them feel like you're not saying it directly, but you're communicating that they are only their past. They're only their trafficking situation and experience. We teach our students to not even ask the number or even really focus on that because it's not going to change clinical management. And so that's one of the things we really try to focus on, because that is probably why some people don't identify, is because they're so turned away from the fact that those questions and the way we ask them are projecting shame and judgment without us even recognizing it, having this unconscious bias because of some of the questions that we were trained and taught to use as medical students.
I think that's actually a really great point. I think that's something that goes back to what you guys were saying earlier on, is that if you can catch learners early on in their medical training, specifically with regards to these topics, you can try to address some of these inherent biases that they might not even be aware about. So that's actually a really great point. I think as time is running out, I just wanted to first thank you guys for all your time and all the expertise that you guys have imparted on this episode. Because again, I said at the start of this episode, this is definitely a blind spot for a lot of individuals out there because they don't really get formalized education. So to have your expertise here and to have your guidance on some of these challenging issues and how to navigate through some of these dynamics, I think was incredible. So thank you guys so much for your time. Do you guys have any place where folks could reach out to you for questions, or any social media platform that they can follow you on if they have any questions regarding topics like this?
Yeah, they can always email us. We are always open for an email. My last name at Schaff, SCHAFFK at odu.edu. And then we also have a social platform that's Red Flags to Freedom that Megan is in charge of for her nonprofit, and then her email as well.
Yeah, and my nonprofit also has an email that is just contact@Red Flags to Freedom, where we can give additional resources and how to get involved, whether in Virginia or in other states as well.
Awesome. And what I'll do is I'll actually link that in the show notes. So for anybody that's interested in having access to these resources, or even trying to develop something in your medical education, or even outside of your medical education, you guys will have that resource there as well. So I'll link that in the show notes. Thank you guys for all your time today. For the listeners, what have you guys done to incorporate education regarding human trafficking, and how have you tried to address some of these biases that our younger learners might have and not be able to navigate through these challenges? Let us know, and let's keep the conversation going. Thank you guys again for joining me for such a great episode.